The Radiology Review is pleased to offer the Board Exam Study Guide, episodes 1 through 101, available for purchase as a book on Amazon or in Kindle version. Welcome to the Radiology Review podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review podcast. This is an educational episode focusing on theranostics in nuclear medicine, and I will begin the episode with questions and answers that are general to theranostics in nuclear medicine. Afterwards, I will focus on questions and answers specific to lutetium-dotatate therapy, for which the current trade name that is often used is Lutathera. I then plan to release specific episodes on PSMA-based theranostics, and we will also go back to the original theranostic agent, radioactive iodine. Before I get into the questions and answers on this episode, I first want to read a portion of an email that I got titled, "Thanks from Australian Residents," and this email was sent from Daniel and Ray in Melbourne, Australia. This says, "My colleagues and I from Melbourne, Australia just wanted to say a massive thank you for your amazing podcast and social media educational resources. We recently sat our final board exams, and the material you released, hours we spent driving with you in our ears, made all the difference. We're happy to say that many of us passed with the help of your teaching. We look forward to being ongoing listeners in the years to come. Keep up the amazing work and helping generations of trainees to prepare to succeed." Thank you so much, Daniel and Ray, for this message. One of the greatest privileges of this podcast is having a reach that extends well beyond my location in Salt Lake City, Utah, and provides an educational forum that allows future radiologists like you to prepare to succeed while you do things like commute, exercise, or do other things where a book or screen is not generally possible. I also want to remind listeners that there is a discount code section on my website, theradiologyreview.com, where you can frequently find discounts for things like board preparation and educational resources in radiology. Without further ado, let's get into the questions and answers for this episode. First question: what is meant by the term theranostics? A theranostic agent generally means using a radioactive imaging agent and paired or identical therapeutic agent that both have uptake at the same molecular target, receptor, or process for use in both therapy and diagnostics. Therefore, the combination of therapy and diagnostics has been made theranostics. Next, what are some of the most common theranostic agents in clinical use? Perhaps the most established example of a theranostic agent is iodine-131. One can perform imaging on a gamma camera and treat thyroid disorders with iodine-131. Therefore, this is both a therapy and diagnostic agent, and therefore this is a theranostic agent. Agents such as iodine-131 allow you to first image to confirm if the intended target shows uptake, and then confidently treat the patient with a therapeutic dose of I-131 with good assurance that the therapy will localize to the affected tissue since this was first confirmed on imaging. Thereafter, one can image post-therapy to confirm uptake in the intended target and thereafter image for surveillance of disease. All of this is provided with iodine-131, a theranostic agent. In this example, the gamma rays emitted by I-131 allow diagnostic imaging, and the beta particle of I-131 allows therapy. More recent theranostic agents are lutetium-177-Dotatate, which is a therapeutic agent, that has been paired with copper-64-dotatate or gallium-68-dotatate, both of which can be used in PET-CT imaging because copper-64 and gallium-68 are both positron emitting, and then the therapy can be provided with lutetium-177, which emits a beta particle. This theranostic pair can be used for various somatostatin-positive malignancies to include various neuroendocrine tumors. Another example is lutetium-177 PSMA paired with F18 or gallium-68 PSMA, which can be used for the diagnosis and treatment of metastatic prostate cancer in certain scenarios. Next question. What radioactive particles are typically used in nuclear medicine therapies? Hopefully this is an easy answer to reach for you, and the answer I'm looking for is alpha and beta particles, both of which are used in most current nuclear medicine therapies. For example, I-131, Y-90, and lutetium-177 all use beta particles. Radium-223 and actinium-225, for which there is currently a lot of enthusiasm for new theranostic agents, are examples of current and emerging radionuclides that use alpha particles for therapy. Next, considering alpha and beta particles, which particle is larger? The answer I am looking for is definitely the alpha particle, which contains 2 protons and 2 neutrons and is therefore a helium nucleus. The alpha particle is larger than a beta particle, which for therapy purposes are electrons. Alpha particles are something like 8,000 times larger than beta particles. Next question. Which particle travels a greater distance in human soft tissues, alpha particles or beta particles? The answer is that beta particles travel a greater distance in soft tissue than alpha particles. Beta particles are smaller and highly energetic, allowing them to penetrate around 3 to 4 millimeters in human soft tissues. In comparison, the much larger alpha particle only travels something like 50 to 100 micrometers, or 0.05 to 0.1 millimeter in human soft tissue. So the alpha particle is much larger and also travels a much shorter distance in human soft tissue than does a beta particle. One could ask themselves, which particle is superior for nuclear medicine therapies? The answer I have arrived at, for now at least, is it depends. Alpha particles undoubtedly cause more local damage and are more lethal in the local environment in which they deposit. The short traveling range also can limit off-target radiation exposure, which can spare things such as adjacent normal, bone marrow, or normal lung from radiation exposure. On the other hand, beta particles can travel further, and in some instances this may be beneficial to kill a larger area of tumor than merely the region where the particle deposits, which could be particularly helpful for things like tumor heterogeneity, wherein part of a tumor may take in the particle and part of the tumor may not. Therapies based on beta particles, in theory, could kill portions of the tumor that does take in the beta particle, as well as portions of adjacent tumor that does not. Therapies based on beta particles are also sometimes easier to produce. A final point. Many nuclear medicine therapeutic agents deliver some dose to the bone marrow, as well as organs like the liver, kidneys, bladder, and possibly the colon as part of the excretion of the agent. Therefore, many therapies require adequate renal and liver function levels, adequate blood counts, such as white blood cell count, red blood cell count, hemoglobin, and platelet levels, as well as frequent urination and defecation during therapy to minimize toxicity that can result from the therapy. Now let's transition specifically into questions and answers on lutetium-177-Dotatate. First, lutetium-177-Dotatate can be used for treatment of certain somatostatin-positive neuroendocrine tumors. What are the most common sites of neuroendocrine tumors? Gastrointestinal sites are most common, and in order of gastrointestinal prevalence, it is the small intestine, followed by the rectum, followed by the colon, followed by pancreas, followed by appendix, and finally the stomach. And the gastrointestinal sites are most common in general, followed by the respiratory system. Note that 5-year survival is higher for small intestine neuroendocrine tumors at about 70%, compared to rectal neuroendocrine tumors at about 30% for 5-year survival. Next question. True or false? Lutetium-177-Dotatate is considered a peptide receptor radionuclide therapy, and this is often abbreviated PRRT. The answer here is true. PRRTs, or peptide receptor radionuclide therapies, involve a radiopharmaceutical connected to a peptide that binds a specific receptor to selectively target and treat cancerous cells. As mentioned, lutetium-177-Dotatate emits a beta particle, which is a high-energy electron, which kills tumor cells via free radical formation following receptor binding and internalization into the cell. Gamma rays are also released, which can be imaged using a gamma camera. Next, what receptor type does lutetium-177-Dotatate bind to? Lutetium-177-Dotatate is a radiolabeled somatostatin analog that binds to somatostatin receptors with highest affinity binding for somatostatin type 2 receptors. Next, what types of neuroendocrine tumors does lutetium-177-Dotatate currently have approval to treat? Lutetium-177-Dotatate is currently FDA approved for treatment of somatostatin receptor positive gastroenteropancreatic neuroendocrine tumors, which is often abbreviated GEP for gastroenteropancreatic, GEP NETs for neuroendocrine tumors. Next, what is the typical dose and duration of treatment of lutetium-177-Dotatate for gastroenteropancreatic neuroendocrine tumors? Currently, a fixed dose of a 200 millicurie intravenous infusion of lutetium-177-Dotatate is given every 8 weeks for a total of 4 doses. If toxicity develops, the interval may be extended to 16 weeks from every 8 weeks between treatments in certain cases. The intention of this is to allow additional time between therapies for toxicities to resolve. Next, true or false? You can treat a patient with lutetium-177-Dotatate while currently taking long-acting somatostatin analog therapy, such as octreotide LAR. The answer is false. Long-acting somatostatin analogs need to be discontinued for at least 4 weeks prior to initiating lutetium-177-Dotatate therapy. Next, true or false? Short-acting somatostatin analogs must only be discontinued 24 hours prior to initiating lutetium-177-Dotatate therapy. The answer here is true. Short-acting octreotide only needs to be discontinued at least 24 hours prior to initiating lutetium-177-dotatate therapy. Next, what is guidance for use of octreotide therapy during lutetium-177-dotatate treatment? Intramuscular octreotide LAR is administered between 4 to 24 hours after each lutetium-177-dotatate dose. However, octreotide LAR must not be administered within 4 weeks of each subsequent lutetium-177-dotatate dose. Remember that lutetium-177-dotatate is administered every 8 weeks for a total of 4 doses. Short-acting octreotide may be administered for symptomatic relief during lutetium-177-dotatate therapy, but must be discontinued at least 24 hours before each lutetium-177-dotatate dose. After completion of all doses of lutetium-177-dotatate therapy, octreotide LAR may be given every 4 weeks until disease progression or for up to 18 months following treatment. Next, true or false? Amino acid solutions are given prior to lutetium-177-dotatate infusions. The answer is true. An intravenous solution of amino acids containing L-arginine and L-lysine is given 30 minutes prior to lutetium-177-dotatate administration and is continued during and for at least 3 hours following the lutetium-177-dotatate infusion. The amino acid infusion and lutetium-177-dotatate can both induce nausea and vomiting, so antiemetics are typically given prior to starting the amino acid infusion. Next, why are IV amino acids started 30 minutes prior and continued throughout and following lutetium-177-dotatate infusion? Lutetium-177-dotatate is renally excreted. The amino acid infusion is given to protect the kidneys from excessive radiation dose and lowers radiation dose to the kidneys by up to about 50% through reducing the tubular reabsorption of lutetium-177-dotatate. Next, what are potential treatment and management steps for cases of lutetium-177-dotatate extravasation? If lutetium-177 extravasates, first, stop the injection and remove the IV catheter. Keep the IV catheter and infusion materials, such as tubing, to allow measurement of residual activity to determine the absorbed dose that was extravasated. Elevate the affected arm to accelerate dispersion and prevent stagnation in tissue. In certain cases, aspiration of extravasated fluid, a saline flush, application of a warm compress, or heating pad may be used to increase blood flow and promote dispersion of extravasated lutetium-177-dotatate. Finally, treat symptomatically for inflammation or pain. Next, what radioprotection measures are taken during lutetium-177-dotatate treatment? During administration of lutetium-177-dotatate, isolate the patient and ensure radiation emission limits to others are not exceeded during and following the lutetium-177-dotatate administration. This often requires initial isolation for something like 4 to 5 hours. Patients should stay well hydrated and urinate as often as possible in a designated hospital toilet that is appropriately isolated. The patient should not be discharged until it is deemed safe to leave the designated area or hospital, according to institutional or government policies. After leaving the hospital, a patient should continue to stay hydrated, urinate frequently, and defecate at least daily, using laxatives as needed. Close contact with others should be restricted per institutional radiation safety protocols. Prior to discharge, the nuclear medicine physician must outline radioprotection rules to others. Next, what lab tests are typically monitored before and after lutetium-177-Dotatate treatment? Lab tests that are typically monitored include kidney and liver function tests and a complete blood count before and every 4 weeks during treatment, to be continued at least 3 months following the last infusion of lutetium-177-Dotatate and every 6 months thereafter to assess for any potential delayed adverse reactions. Last and final question for this episode. If toxicity sufficient for dose modification occurs, how is this handled? General principles include first withholding lutetium-177-Dotatate therapy and thereafter monitoring relevant labs every 2 weeks. If toxicity resolves within 16 weeks of the previous injection, lutetium-177-Dotatate therapy may be continued, though it would be continued at half dose. If dose-limiting toxicity recurs at half dose, treatment should cease. If the initial dose-limiting toxicity does not resolve after 16 weeks of the most recent prior injection, therapy should not be reinitiated. A few final points. A negative pregnancy test needs to be confirmed for individuals of childbearing potential prior to lutetium-177-Dotatate administration. Patients should not breastfeed during lutetium-177-Dotatate treatment and for something like 2.5 months following the final treatment infusion. Effective birth control should be used during and for at least 4 months for males and 7 months for females following the final infusion of lutetium-177-Dotatate. During treatment, patients should be monitored for evidence of neuroendocrine tumor release, which includes symptoms like flushing, diarrhea, hypotension, and bronchoconstriction, and symptoms should be treated with fluids, corticosteroids, electrolytes, and possible intravenous somatostatin as clinically indicated. Patients also need to be monitored for evidence of hypersensitivity reactions, including anaphylaxis, during and for at least 2 hours after completion of infusion. If hematologic or other toxicity occurs, such as renal or hepatic toxicity, treatment may need to be withheld or restarted at a lower dose. Finally, as a special disclaimer, this information is for educational purposes only. Please refer to institutional guidelines, society guidelines, and the FDA label for any question on clinical use of lutetium-177-Dotatate or other nuclear medicine therapies. Again, this information is for educational purposes only and is intended merely for board preparation purposes. That is enough for now. I hope this information is helpful for many of you. A free downloadable study guide on this topic is available at my website, theradiologyreview.com, so check that out. Also, remember to check out the discount code section of my website. While you are there, you may also want to check out articles of interest to radiologists and nuclear medicine professionals at the Radiology Review Insider, with my most recent post on supplemental breast cancer screening, a topic for which I am deeply invested and which I feel is deeply important. So if you would like to learn more about supplemental breast cancer screening, check out my post at the Radiology Review Insider or listen to the podcast episode on supplemental breast cancer screening. Keep up the good work and study hard. Remember, you have to study really hard to succeed on radiology board exams. So prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.
What's better than listening to the Radiology Review?
Nothing.
Well, true. But you could buy our book, The Board Exam Study Guide, Episodes 1 through 101, available for purchase as a book on Amazon or in Kindle version.